So once again, very, very grateful and thankful to Dr. Sapp for presenting the webinar today. She is Clinical Director and owner of OCD and Anxiety Psychological Services in Calgary. She has extensive experience treating children, teens, and adults with OCD. She's a board member of the Scientific Advisory Committee of Anxiety Canada and a credentialed member of the Canadian Association of CBT. She provides training and supervision to therapists as part of the Pediatric Behavior Therapy Training Institute for the International OCD Foundation, and annually since 2008 presents OCD and anxiety-related workshops in the USA and Canada. I hand it over to you, Dr. Sapp.
Okay, I'm just going to get to sharing my screen here. How do I do that? Oh, wait, sorry, I'm on the wrong thing. There we go. Okay. So thank you very much for that kind introduction, Julian. And I'm just going to, there we go. And I just want to get rid of all this. Okay, thank you for that kind introduction. And today I am here to talk to you about exposure and response prevention treatment for pediatric OCD. And I'm going to focus on developing and implementing ERP today, also through case presentations as well. Oops, sorry, just a second. So these are my disclosures, and I don't believe there's anything that impacts what I'm speaking about today. So by the end of the webinar, I'm hoping that you're going to be able to describe the steps of ERP treatment, create individual fear hierarchies related to a specific fear, and be able to implement ERP treatment, and be able to apply and adapt creative techniques to ERP treatment based on the age of the child or the teen. Now, OCD affects anyone and everyone, and it does not discriminate, not even to Santa. You know, you used to only check it twice. Now it's 5, 6, sometimes 7 times a night. Come to bed already. Here, St. Nick's obsessive compulsive disorder is now becoming disruptive to his home life. And that's really what we see. Whoops, sorry. Typically, you know, we hear these comments of, I'm so OCD, or OCD is just about being neat. Or being a bit finicky. And the reality is these types of comments actually diminish the impact that OCD does have on people's lives. OCD is a true mental health disorder. It is a neurobiological disorder, and it is the way that the brain is wired. There is a false fear message that's coming from the amygdala. And even though the message is a false alarm, the body doesn't know the difference, and it acts as if the danger is real. And so in order to take back control from OCD, we need to retrain that amygdala to change the wiring in the brain. So what is CBT for OCD? Well, the cognitive part is teaching the youth to respond differently to the obsessions. And the behavioral part is changing the actions used to decrease anxiety. On the last webinar, I focused a lot on the cognitive therapy, and today I'm going to focus a lot more on the behavioral therapy. So the behavioral part of CBT is something called exposure and response prevention therapy. Exposure is where you expose the patient to a triggering situation, place, object, thought, or feeling. And you can do this in a flooding way, like jumping right in, or in a more gradual way. And then the response prevention aspect is where you're encouraging the patient or child to refrain from doing their ritual. Now, one of the things you want to have the children and teens to understand is what's going to happen when they're doing ERP. And you want them to understand that, you know, at first, when you don't do what OCD wants you to do, you're going to feel this icky feeling. But if you continue to not listen to OCD, eventually that icky feeling is going to go away. So with exposure and response prevention, you want to be helping your patient understand that they need to refrain from doing the ritual, but not just the ritual, any behavior that is going to bring down anxiety. Now, Dr. Paul Munford talks about false fear blockers. And the reason he calls these false is because they prematurely bring the anxiety down. And in order for habituation to occur, the anxiety needs to come down naturally. And we also want the idea that, you know, the more they do over and over again, the easier it's going to get. So we want to kind of do multiple trials. And by doing ERP, the child is going to learn that if I do not engage in my compulsion, that anxiety is going to come down all by itself. They're also going to learn that that wasn't fun, but I'm actually able to tolerate that anxiety better than I thought I could, and that their feared consequence does not necessarily happen. Now, when we look at a review that was done, they were looking at different studies where CBT with ERP is being compared to CB without ERP, and then just cognitive theory by itself. And what they found is that when we include the ERP, that it was the OCD severity scores were lower post-treatment than with the other two modalities, which really is showing us that this ERP aspect is necessary. And so we are seeing that it is the first line of psychosocial intervention for children and adults and children and teens. So really with OCD, and what we're trying to do is we're trying to retrain that amygdala. And you can't talk the amygdala out of its fear because it's in the feeling part of the brain, so it just needs to feel that it's not dangerous. And so by acting as if the situation is not dangerous, by staying in contact with that trigger and not doing the ritual, then eventually the amygdala learns that the anxiety goes down, and that's how habituation occurs. And then once the amygdala learns that it's not dangerous, then it will stop sending that false alarm. So in the last webinar, I focused on getting ready for treatment, and today I'm going to focus on rewiring the brain and taking it into the real world. Before I get into that though, I want to talk about what a typical session looks like. So when we're first starting, you're going to want to check in with the parent and the youth. And again, depending on the age of the child, with younger children, the parents will be in there at the beginning. And then with teens, I may not be checking in with a parent every time, but I'm going to want to check in every few times and sort of get their input on how they think things are going. You're going to spend time reviewing the assigned ERP tasks that you gave. And the reason you want to do this is, first of all, you want to show interest because you did assign them. And it helps the child and teen be accountable as well, and helps with motivation. And then the majority of the session is going to be spent on developing and then testing out new ERP tasks. Now, this is not talk therapy. We are doing stuff. We are doing actions all the way through. And so you're going to have them test out what they did for you for homework. You're going to look at, okay, what changes do we make? Is this too hard? How do we move to the higher levels? And come up with new ones. And you're going to test them out. Because it's really important to kind of see how they're doing with something new before you ask them to practice that at home. And with parents, with children, I'll have parents in that session observing me doing ERP and then maybe participating and then even leading it. Now, finally, at the end, you're going to talk about what are the assignments that they're going to be doing next time. And those are going to be the things that you did practice in the session. So I'm going to talk a little bit about exposure response prevention. Before we start, we have to find out what that core fear is. So lots and lots of questions to really individualize the treatment. From their journal, you're going to identify triggers and behaviors they're avoiding. You're going to rate each of those using a fear thermometer with young kids, an anxiety scale with older. Arrange these triggers on a bravery ladder or a hierarchical scale related to one specific fear. And then you're going to start with the items on the lower end of the scale and work your way up. Now we want to start with those lower items because they're the ones that are less anxiety provoking. And so it's going to allow the child to experience success, which again will increase that motivation to do the work. When we look at some adult exposure therapy, there was a review that looked at different ways that you can present the triggers. And when we do what's called a compound exposure approach, where you expose to one trigger, then to a second trigger, and then both together, we find that it maximizes habituation rather than just being exposed to one single trigger. And this is something that I do a lot when I'm doing ERP. And also I want to just note too that even though those highest rated triggers are up at the top there, we're not necessarily going to wait to the very end of treatment before we get to them. In fact, often it's partway through treatment that we are getting to those high triggers. Now, we wait till they come down, till their anxiety is lower to address them, but we're going to try them in different contexts, changing different variables, and this allows people to be able to then practice and then be able to generalize and take it to opportunities in real life. So the steps of ERP. First, you want to expose your patient to the trigger situation or object. You want them to use the fear scale to rate the anxiety level. And they're also going to record how long it takes for that anxiety to come down. You want to teach the youth that you have to allow whatever scary thoughts or images come into your head to just be there, and we're not going to push them away. And not only teaching the youth, but we also have to teach the parents that you can't engage in any behavior that's going to help them feel better. So there's no kind of relaxing breathing while we're doing this. No telling myself everything's okay. And parents need to understand that they can't rescue the child from that anxiety. And finally, because we want them to encourage them to feel the anxiety, let the thoughts be there, and then just let it come down all by itself. And then finally, we want parents involved, again, depending on age. Often parents with younger kids, they can be the recorder, and then of course, rewarding for being brave or for doing the ERP assignment. So here's just kind of an example. So this might be a trigger. So as you can see, it's a compound exposure. We can assume we've done both of these individually first, and now we're looking at the word knife and seeing a picture of a knife. And as I'm doing that, now these thoughts start to happen. Oh my gosh, what if I take that knife and stab someone? What if I lose control? Oh my gosh, maybe I'm crazy. So I have to allow these thoughts to be there. I'm going to use my fear scale and rate how anxious I feel with these thoughts being there. And then what I want to do is just sit with it and just let it be there and wait for it to come down. Now, some common pitfalls that we see sort of with new therapists is basically not identifying or teaching patients how to resist mental compulsions, unintentionally providing reassurance for the patient, and kind of not knowing sort of how far and when to move patients into higher anxiety-provoking situations or pull them back, not engaging significant others in treatment when it's needed, not using imagined exposure effectively, allowing distraction, allowing relaxation during ERP, and not informing parents when they're interfering with the treatment process. And then also getting into a situation where the youth is arguing or rationalizing with you. Now, in a more recent study, we see how therapists' beliefs can get in the way of treatment. Some of these negative beliefs are things like, they can't tolerate the anxiety, so I need to teach them anxiety reducing techniques. Another common one is not all obsessions are appropriate for ERP. Okay, so I want to talk now about fixing the false alarm. So these are different types of exposure prevention tasks that I'm going to go through. So first of all, planned ERP. When we're explaining it to the patient, you want them to understand that this is the gold standard. This is the formula to fix that false alarm that is happening in the brain. They need to feel distress. If they're not feeling distress, then they're not getting any benefits from it. So they need to feel distress in order to be doing it correctly. They need to stay in the trigger situation long enough for the anxiety to decrease at least 50%, if not more, in order for that amygdala to get retrained. And the amygdala doesn't learn instantly. It needs repetition and consistency. And so it's that idea that if we do it over and over again, the easier it's going to get. I often want to explain it by if you're learning a new skill. So finding out what they're interested in, whether it's gymnastics or dance or hockey. If you practice that skill once a day for a week, are you going to be better or worse than if you practice it once a week for 7 weeks? And then I want them to understand that you're not going to have to do this for the rest of your life. We're only going to have to do these planned ERPs until that brain gets retrained. And then once it is, then we don't have to do them. So planned ERP, what are we going to do with the clients outside of the session? So with younger children, we're going to be assigning 30 to 45 minutes a day. Teens might be up to 60 minutes a day. And the reason we want to assign tasks outside of the session is that we see that between session compliance actually predicts success more so than just within session compliance. We also see that if people do up to 90 minutes of planned ERP a day, we can actually retrain them regarding that particular trigger within about 5 to 7 days. We want those sessions to be long enough that they are experiencing several trials in that same session, because that gives them an opportunity to experience both within and between trial habituation, which is needed for the amygdala to learn. So we want that repetitive, planned, frequent. And the idea, letting them understand, the more you do, the faster you're going to see results. It's kind of that idea of short-term pain for long-term gain. What you're going to be assigning, the ERP tests you're going to assign, are going to be the ones that you have practiced with them in session. And we want to ensure that we have rewards that are being earned for doing this brave behavior and bossing back OCD. Now, day-to-day ERP, it's important for the parents and the child to understand that, every time that OCD shows up, you can't just stop for an hour or 40 minutes and just let that anxiety come down. We actually need to know, how do I respond to OCD when it just pops up out of the blue for in the middle of the day? So we want to teach them that you need to recognize those automatic mental rituals that you're doing and then bring back the fear to neutralize them. We can't use distraction or reassurance, but we want to bring them back. If they're only resisting rituals during the ERP task, but in real life, they're actually doing their rituals when they're triggered, then all that's going to end up happening is they're going to sensitize their fear, and their brain is just going to end up reverting back to the old wiring. Okay, so we're going to want to assign day-to-day ERP tasks. Now, you're typically not assigning these types of tasks until they've mastered kind of the planned ERP. So it's not done at the very beginning of treatment, but a couple sessions in once they're able to do the other. You're going to want to have purposely trigger in the background of day-to-day living. So it's the idea of like surrounding yourself with your fear so that they're exposed to it throughout the day. Often I incorporate parents and get teens permission, but often, you're going to be incorporating parents to be able to triggering them throughout the day. And when they are triggered, you want them to respond to that obsession with uncertainty. Let the fear be present. Yeah, maybe something bad could happen, maybe not. Feel the anxiety. And then once the distress kind of goes down just a notch, then we're just going to move on with our day. And then I want them to note in their journals throughout the day when they've bossed back OCD, and then get them rewarded for those brave behaviors. But we also want them to note when OCD won, when they ended up doing their ritual, so that we can use that down the road for another trigger. Now, imagined ERP is important to include in treatment because we see that when we combine it with in vivo ERP, that there's more gains if we're then rather doing just real life ERP. Imagined ERP can be a first step before you start real life ERP. So it allows the youth to just become comfortable with the icky feelings in a non-threatening situation. You can write this at various anxiety levels, so we can make it easier and harder. And what it really does, it allows the youth to face the fears that we can't create in real life. We're not going to make mom have a car accident, but we certainly can imagine it. And finally, it allows them to kind of engage in the thoughts that they've been avoiding, which helps break that false alarm, and then they eventually habituate. You can kind of think about it as the idea of watching a scary movie. So when you watch a scary movie over and over again, that more times you watch it, you're going to expect, so you can anticipate it, and then eventually you get bored with it, or you get used to it. It's important to look at how much families are involved. Families often are entangled into the OCD, and they're accommodating in different ways. So we need to assess their involvement, and this is a great scale that you can use. And then once you assess how much they're accommodating, then you may need to set up some behavioral contracts with the child and the parent, or with the teen and the parent, to start to reduce that. I always want parents to understand that, even though you as parents can understand why your child might be having a temper tantrum, or why they might be swearing at you or yelling, you still have to set limits. You have to have family rules, you have expectations on behavior, and we still have to set those because we need to normalize life for the child or teen as much as possible. Okay, what I'd like to do is talk to you a little bit about Sally. Now, what I'm going to do is I'm going to go more thoroughly through this case presentation with Sally, and then I have several after where I'm just going to be doing a more abbreviated form. So Sally was a 9-year-old, and she had severe anxiety that had been present most of the day for about a year. And it was initially about getting a cold or the flu, but in the past year, it had just become worse, where she was afraid of throwing up, getting sick. And by the time I saw her, she was engaging in lots of hand washing, and her hands were just raw. There was a family history on both mom's and dad's side, and the brother experienced anxiety. And when I saw her, she was diagnosed, I diagnosed her in the severe range. There was a lot of family conflict going on because she was just so distressed, and parents were trying to keep the peace, so they were just kind of giving in. So Sally's obsessions were a fear of germs and a fear of throwing up. Her compulsions were excessive washing of her hands, as I mentioned earlier, and repetitively asking her parents if she looked or felt fine, or if others looked or felt fine, especially her brother, because OCD targeted him. And she avoided a lot of things. She avoided anything that she deemed as contaminated, and particularly things had gone to school. And she was doing this spitting to just get rid of the germs. So she was spitting to prevent herself from getting sick. So initially, I talk a little bit about getting ready for treatment. And with Sally, just kind of given her age, talking in kind of child-friendly terms, talking about OCD as a bully that was bossing her around. And so she came up with this nickname of Mean Machine. And this is a picture of her Mean Machine. And he had down at the bottom, we're kind of like, you're going to get sick. And we talked about Mean Machine as a bully, had been bossing Sally around. And aren't you tired of listening to him? And now it's time to take back control. Given her age as well, rewards and an incentive program was a big part of this to get her to do the work, because she really was distressed, feeling a lot of distress. So we came up with a token program where she was earning tokens or that she could cash in for small rewards or bigger rewards. And we also created what I call a Brave board. And it was just kind of a big Bristol board that they put, I think, in their dining room. And any time that she bossed back Mean Machine, we took like a sticky, and they would write it, put it up there. And so what this gave her was a real visual of the successes that she had in bossing back Mean Machine. And we talked, by externalizing OCD and calling in Mean Machine, which we did from then on, it really sort of takes away the blame from the child and helps sort of us be allies with her against Mean Machine, and raises her confidence. And then finally, I had to kind of use games and try to make bossing back Mean Machine as fun as we possibly can. Okay. So it was important for parents and Sally to understand that we need some tools that she's going to need to fight back Mean Machine. And again, given her age, concrete objects were used a lot. So her journal was a main one. We created a fear thermometer. I don't have one here to show you. I showed people one in the last webinar, but it was the same idea. We created a fear thermometer that she could use to sort of rate how much Mean Machine was bothering her. We made a map of her life to kind of see, okay, where is Mean Machine in charge? Where are you in charge? Kind of determine where we were going to start. And then we had a bravery ladder. It was important for Sally and her parents to understand that anxiety is not the problem. The obsessions are not the problem. It's that what's going on in the brain. It's that error message, that false alarm, and the compulsions that she's doing. And yes, Mean Machine scares her so much to believe that she has to do these compulsions, but the reality is the choice is hers. And so we have to treat the fear and not just the anxiety. So we know that the only way to get over this fear is to go through it. We can't go around it. We need to face it in order to erase it. We have to have them welcome uncertainty. because the only way to take back control from OCD is to accept the possibility that what you're afraid of is possibly true. And we want parents to particularly understand that we can't argue or try to talk the child out of the fear and challenge the reality, because all that's going to happen is OCD is going to bring back the doubt and the feelings of guilt, and then it will win that argument. So Sally's fear, we looked at her journal. I had her be a detective, and she was investigating Mean Machine. She, finding clues and evidence of what Mean Machine was scaring her about. And we came up that it was a fear of getting sick and throwing up, but not so much of like getting an illness. It was more that it's just gross. So we had a bravery ladder, and it was around a fear of vomit. So I'm just going to show you a list of some of the items on her bravery ladder and the anxiety level she gave them. So you can see down at the bottom are the ones she rated lower, up at the middle are the moderate, and then up at the top are the hardest ones. And when we started ERP, we started down on the lower rungs and had her sort of work her way up. And one of the things that I like to do is, so that the child, you're collaborating with them, is when there's sort of the items that are rated about the same, is to have her choose which one we're going to address. So I want to show you a couple of some of her planned ERP tasks. So we started off with, playing some games with these pictures. We started off with like pictures of emojis, and not even the throw up one, just one's looking sick. And then we got to the throw up one. And then we went to animated pictures of people looking sick and throwing up, and then real pictures. And we played games with those. We played hangman with the words and phrases she didn't like. And so when I'm assigning these tasks, I sort of, especially with these younger age, I'll have kind of like, half of it's going to be doing games, half of it's kind of these arts and crafts. And so in session, she and I, we had a whole bunch of pastels, and we drew throw up emojis, and we made the whole page full of throw up emojis. We had her watching animated movies of throwing up, and touching items that were considered contaminated, and then eating Skittles off the things that she touched that were contaminated. One of the other things we did is we played follow the leader in my office, and not my office, but my office building. And I went around and I touched things that OCD wouldn't want her to touch, or Mean Machine wouldn't want her to touch, and got her involved in that way. Especially with this age, actually, I shouldn't say that, all ages, you really want to model the ERP task for the child. And so I'm having the parent in there doing it with me, and I'm doing it, and so that they can see us resisting her OCD. So I'm going to show you a couple of her sample day-to-day ERP tasks. So these were kind of pictures we drew, and she would put those up. So she took that poster, she put them up in her room, and had to see it every day. We got some vomit sounds, and parents had to play that kind of in the background. And then we had this throw up song. So I had it kind of in the background playing initially while she and I were working together. So she got used to it that way first. That was how we first started with it. And then eventually she was able to sing it with me, and we did actions, and so you can do this, and I did this in a session with her initially, and then they brought it home and they played that in the background quite a bit, and then played games with it as well. For her imagined scenario, one of the things we did was she would tell me her story about her worst fear, and I wrote it out. And I'm not going to read it right now because that's going to take too much time, but basically, once it's written out, we can do a couple things with that. She can either read it, or someone can read it to her over and over again. We can record it, and she listens to it over and over again. You can also, with children, have parents tell them the story, or have the child tell the parent the story. You want to end it with ambiguity, like, it's possible that your worst fear may happen. And then finally, with older kids, sometimes, or very artistic ones, I'll get them to make a comic strip where they are doing their worst scenarios there. With respect to Sally, her mom was really involved in feeling her forehead and giving reassurance that she wasn't sick, and was happening multiple times a day. So we needed to get a baseline, and it was about 40 or 50 times a day. Then we broke it down into different time periods and rated that according to how much it bothered her. And then we gradually reduced the reassurance, and in one time period, once she was comfortable with that, we moved to other time periods as well. And then parents' job was to allow Sally to sit with that uncertainty that she may get sick and throw up, and to not rescue her. And Sally's job was to feel the icky feeling, rate it on her fear thermometer, and just let it be there. One of the things we did as a reward, I mean, she was rewarded in other ways, but sort of an extra reward for this one, was we gave her a series of quarters. And basically every time she wanted to give reassurance, she had to pay a quarter. And by the end of the day, whatever was left over, she was able to keep. I'm going to talk now about an older girl. She was 16, Maddie, and her anxiety had been there for a while, but in the past 3 years, there were some unusual behaviors that were happening and kind of getting in the way of her functioning. And there was a family history of anxiety and mood. She was diagnosed with moderate OCD, and things were starting to get in the way of her functioning. So her obsessions were a fear of something bad happening, a fear of this feeling of grossness, or this icky feeling that would never go away. And her compulsions or rituals were repetitive behaviors, and she did these in counting in multiples of 4. There was a lot of repetitive asking, if she was okay and other family members were okay. She would avoid touching anything considered gross or dirty. And she had these elaborate superstitious behaviors. So she had to walk a certain way on the floor. She couldn't touch certain parts of the floor in order to prevent something bad from happening. So Maddie's fear was this fear that this gross feeling would not go away. So we made a fear ladder of just right and something bad happening. And by identifying triggers in her journal, and I'll just show you a couple of the items on her fear hierarchy and the ratings that she gave them. So you can see down at the bottom are things like not putting her personal items in the bathroom in just the right order. Up at the middle are things like stepping on that bathroom mat once only versus 8 times, which is what OCD wanted. And when we started with that one, we went from 8, and then we went to 4, and then to 2, and then eventually to 1. Allowing gross items in her room, allowing gross items in her bed throughout the night. These were up at the very top. So some of her ERP tasks, the planned ERP tasks were looking at gross items, touching the gross items. And again, even with teens, you can involve games. And so with her, what we did is we created a game of who can touch the grossest item, kind of like Fear Factor, but gross factor, and had her parents involved in that as well. She had to reduce the number of repeats that she was doing and sit with that uncomfortable feeling, and then even just doing a collage of all these gross items. Okay. Her day-to-day ERP tasks were things like walking up the stairs without repeating. OCD, when she'd go into a room, OCD would tell her how she had to come out of that room. So doing the opposite of what OCD wanted. And then also we needed to have her reduce the number of texts that she was giving mom throughout the day. She was texting mom many, many times. And so we, again, broke that down into time periods and eventually reduced it. Okay, I'm going to talk about Tom now. Tom was a 12-year-old, and he was having intrusive thoughts like, what if I'm gay? And he was really distressed with them. He was saying things, I don't feel like I'm myself anymore, and I want answers. He'd always been a sensitive boy. There was a possible OCD on dad's side. And when I saw him, he was diagnosed in the low end of the severe range. So sorry, there was a little bug. His obsessions were a fear that he was attracted to boys, and that a fear that meant he was gay. His compulsions were trying to figure it out. So he did a lot of compulsions in his head where he was trying to, talk himself, figure out and challenge it and try to figure out if he was gay. He also would ask parents around that as well. He would avoid looking at boys in his class, and he would avoid sort of touching, in sports, kind of a little tap. And he was always testing himself for attraction whenever he would see a boy at school. Now, before I get into talking about his planned ERP tasks, one of the things I want to mention is that when it comes to these types of obsessions, like sexual obsessions, harm obsessions, and you're working with children, you really need to include the parents and get their input on the triggers that you're going to be using. With children, we don't have to go as extreme as we would with adults, but we still need to go pretty far in order to make sure we're going after what OCD is saying. So I kind of say that wherever OCD takes them, we have to go there too. So for example, we had, looking at pictures of boy models, and then we had, first the face, and then kind of upper chest, and then maybe showing the chest, and again, getting mom's permission. So I'd look up the picture, show it to mom, get their okay, and then we would go forward. We had pictures of boys kissing, and then gifs of boys kissing, gay celebrities, pictures of gay celebrities. And then one of the things that really bothered Tom was boys that wore makeup. So we had him watching videos of boys putting on makeup. Some of his day-to-day tasks were, we played card games with these pictures of attractive boys. And I had him create a playlist of what he considered were girly songs, and he had to listen to that throughout the day at different times. And then he had a really great set of parents. And so his dad was willing to model the ERP. And so he had his wife put makeup on him, and Tom saw that. And then mom put makeup on Tom, and Tom wore that around the house. And we had him kind of behave in ways that he considered gay. Now, I should say before I had him do this at home, in my office, I have like a tickle trunk. So he had to go in there and find different things. He had like a boa on, and he had to kind of put on a little play for me, and then I gave them as an assignment to make me a movie around this. And then they brought that in to show me. And then whenever he would see an attractive boy, he'd have to agree with the thought that, yep, I noticed him, and maybe that means I'm gay. I'm going to talk now about Mike. Mike was a 15-year-old, and he had had anxiety for a while, but he was having these bad thoughts, and they'd been going on for a couple of years. But he didn't know it was OCD, and he didn't know that like other people don't have these types of thoughts. And so he only told mom once they started to really interfere and cause him to feel really down. He was having thoughts around a fear that he wanted to hurt himself or commit suicide. He was diagnosed with OCD in the high end of the moderate range, and at that time there were depressive symptoms as well. And so for Mike, some of his obsessions were that he had a fear of self-harm. He had a fear that he was just going to lose control and end up killing himself. His compulsions were that he just avoided being alone, so he always needed to be around people. He was coming up with reasons, again, these mental compulsions of why the fear wasn't true. He would try and talk himself out of it. He was confessing to his mom about these fears, and he was really trying to get reassurance from his mom that this would never happen, but also from himself. He was doing a lot of self-reassurance. So there was a lot of mental compulsions here, rather than any physical compulsions. So some of his planned ERP tasks were, again, we started with, I involved mom as well, but not as much because he was older. But we'd looked at pictures of knives, and we started off with just real knives, and then ones with blood on it, and then one with a hand holding a bloody knife. We had real knives, and he started off with just looking at it, and then eventually holding it, and then holding it, sort of hovering above his wrist, and then eventually putting it on his wrist as well. Excuse me. And then I had him get a toy gun, and he had to kind of hold that, pull the trigger, and then even point it at his head, and then had him also write a suicide note. Some of his day-to-day ERP tasks were, excuse me, he created a list of suicide songs, and these would be songs he considered either written by artists who had committed suicide or talked about it. And he had to play that when he was alone or when he was out working out. He also would play it. We went to the cemetery and he would walk around the cemetery and play it there, or he'd listen to an imagined script that we had written. Again, we wanted to include kind of, again, making it less onerous for these teens, which gives them more motivation to do the work. We created a game where we did Pictionary or charades of different ways that you can kill yourself. He watched 13 Reasons Why. And I had him using knives as much as he could at home. So he was the person who had to cut up all the vegetables whenever they were making food. And Mike was a very artistic boy, so he made a short little film on suicide. And he had to agree that, yeah, I'll never know for sure. It's possible I may lose control and kill myself. With Mike, he was unexpectedly triggered by some social media he saw where it was suicide awareness. And so we want to use these as opportunities to turn them into ERPs, because people are going to get triggered throughout their life. So you want him to learn that you're going to respond to that with uncertainty and allow those feelings to be there, and then just move on. In situations where the child or teen ends up doing the ritual, you want them to kind of note that and make a note of it, put it aside, so that we can use it later on when their anxiety around it would be much lower. So Greg was a 6-year-old. He was worrying about dirty hands, he was washing a lot, and he was really worried about being on the toilet. There was a lot of crying and panic going on and involving his parents. And when I saw him, he was in the severe range. He was trying to get mom. Mom had to kind of be there to move him along. So his obsessions were actually a fear of pee, poo, dirt, and germs, and that he would die because of these germs. So he was washing and showering. He wanted to change his clothes after he'd go to the bathroom or shower after the bathroom. He needed his mom to answer all these questions before he could move forward, each on washing hands or even on his toileting routine. And he didn't want to eat any food from his family or anyone's plate. So some of his planned ERP tasks were, we did sort of pictures of comic poop. So we started off with just that, and he had to look at that because that was his fear, was a fear of poop. Then we had harder pictures where he would look at them, and then harder, and watching a video of toilet training, again, in a fun kind of video of that. And then one of the things for the arts and crafts is I found kind of pictures, coloring pictures of poop and other things that he didn't like. And those would be kind of what he would do for his arts and crafts. And then eating food off his parents' plate. His day-to-day ERP tasks, where mom was only allowed to answer a certain number of questions. Once he peed on the toilet, he had to get right off and then be uncomfortable that maybe he didn't finish. And then there was kind of a pee and poop song that we kind of came up with, or they found, that we found online, and they had to sing it at home and so forth. So he actually, his OCD was called Big Meanie. And so because of his age, he was earning stickers every time he bought that Big Meanie, and then he could cash them in for rewards. Okay, now I think I have one more person, which is Anne. Okay, so Anne was a 10-year-old, and she had been worrying for a while, but in the past 2 months, she was just getting all this reassurance from her parents, and it was causing a lot of stress in the family home. There was a family history on both mom and dad's side. And when I saw her, she was diagnosed in the low end of the severe range, and parents were really involved in just keeping the peace and giving in. So her actual obsessions were a fear of hurting people's feelings, and then a fear that God was punishing her for having bad thoughts. And she was having kind of sexual obsessions and unwanted images. And her compulsions were that she was confessing them all to her mom and asking for forgiveness. There was a lot of repetitive behaviors at bedtime going on, a lot of I love yous, and parents had to respond a certain way, so it was taking a long time. She did a lot of checking that she wasn't offending people, so it'd be like, did it hurt your feelings? Are you sure? Are you sure? And just continuously. And then she didn't want to sit on any place that her parents' bums or other people's bums could have touched. So some of the items on her fear ladder were that she had to sit on the couch with her PJs on, bumping into her parents, trying to reduce the number of I love yous, saying the bad words, singing the bad words, and looking at pictures of pregnant bellies were up at the top. So mom was really involved in the confessing. And so we needed to really find out how much that was happening. So we did a good baseline and again, broke it down into time periods and started to change how mom was responding. But the biggest part was what mom was saying. We needed to change her response to uncertainty, which is, yeah, maybe God is upset, maybe not. And then she would be rewarded for being brave and put that in her brave book. So some of Anne's ERP tasks were pictures from this book that her mom brought in, and she had to kind of look at them and let the icky thoughts be there. We did arts and crafts with the bad words and with pictures. Again, playing games. She purposely had to tell her mom a white lie, which she was just terrible at, and her mom was laughing because she's laughing when she's doing it. And then also I had her sitting on the toilet seat at home with her clothes on and just kind of doing a little wiggle dance, but it's one that other people use. Her day-to-day ERP tasks were they created a collage of all these pregnant bellies, and she had to put that up on a wall in her room and look at it, because that's part of what her Bob, I think was her OCD, what Bob was saying is that, you could get pregnant. And so she also had to sit on the couch with her PJs on. Again, for that not wanting to be a bad kid, cheating when she was playing a game. Bumping, we did kind of a butt dancing thing at home where we created a song that she would do. And she was very, she loved music. So she used Garage Band app and created a song that she would listen to over and over. Okay, I want to talk briefly about relapse prevention. So first of all, you're going to want to talk to your patients about how they took over control from OCD and talk about their progress. You want them to understand that they need to be on guard for OCD trying to sneak back in control, especially during times of stress and change, and help them create a relapse prevention plan of how do we keep OCD at bay? What are the lifestyle and stress reduction things we need to look at? And then what do we do if OCD comes back and tries to sneak back in? So here's where I'm going to make them be their own therapist. What would you do if? And get them to do a little bit of a quiz. You want to help them remind that, you've got the tools. You've got these tools. You know how to fight back OCD, and you can use them. And then finally, that offer booster session if that's needed. And it's no different than the maintenance of a car. You want them to understand that they need to not push away the obsessions because they'll just return. They need to change how they're responding to OCD with an I don't care attitude and accept the uncertainty. Do the opposite of what OCD wants. I will look at that boy. I am staying at school even though someone was coughing. I am going to eat chips with my family. And yeah, I'm looking at that boy, so maybe I do like boys. I'm staying at school. I may throw up. I'm going to eat chips with my family. Maybe I will die from those germs. So we need to agree with OCD. Understand that recovery is a lifelong journey and that OCD is going to win sometimes and that that's okay. And that there's going to be these ups and downs. And that once they're able to boss back OCD in a particular situation, they always need to do so. Because if we go back to listening to OCD, then that bully will take over. So finally, as therapists, you want to understand that the fear is important. We don't need to go into the content of the obsessions. We need to help them accept uncertainty and take risks. Do not allow distractions. Do not provide reassurance, even subtle reassurance that happens in sessions, and help them recognize and negate all mental compulsions, and make sure you go after OCD and planned, day-to-day and imagined and in vivo, and that repetition and consistency is key. Okay, and that is the end. Thank you very much.
Okay, thank you, Dr. Sapp, for another great presentation. I would ask attendees to pose your questions on chat now. We have around about just 6 or 7 minutes for Dr. Sapp to respond to your questions. I will just release the post-webinar evaluation now, and please do respond to that while Dr. Sapp is responding to your questions.
Okay, well, one of the questions I see is what ERP manual would you recommend? And in terms of the manuals, there's a couple of good ones. The March's book, what is it called? Just a second. talking back to OCD. And in fact, there's going to, in November, I think it's November, there's going to be a new edition of that one coming out. So that would be, I would be looking for that. It's more updated. And it goes through kind of how to kind of treat OCD kind of in the different steps. And so it's with March and, sorry, I'm forgetting the name right now. Martin Franklin as well. Okay, let's see. What obsessions would not be appropriate for OCD? I'm going to say none. That's one of the things that people think, is that there are obsessions that you can't go after. So the question is, what obsessions would not be appropriate for ERP? So a lot of therapists will have challenges in some of the ones I actually talked about, like sexual obsessions, harm obsessions. But the reality is we have to go after OCD in whatever capacity and whatever way it comes. And if OCD is going to take you to that direction, then we have to go there. So we have to kind of, Dr. Reed Wilson talks about, we've got to fight fire with fire. And if OCD is saying, that you're gay, then we have to go to that direction. I struggle, here's another question. I struggle at times to get younger children to articulate and to get good grasp of the OCD thoughts. Compulsions are easier as they are observable. What would you recommend? Okay, well, in my last webinar, I talked a lot more about this because this is part of the getting ready for treatment aspect, because you do need to have them understand what the obsessions are, but what the fear is. And so with younger children, because they may not be able to articulate it, we can use thought bubbles, where often I will draw the situation and get them to draw it, and then get them to kind of write in what their fears are. I'll also tell stories about other children that I've seen and their fears, and see if they can relate. So you kind of have to give them a little bit of guidance. Okay. Here's another question. Can you do ERP with obsessions around gaining weight and being skinny? So leaning into having the child eat the sugary food instead of avoiding it. Okay, so if their fear is gaining weight or being skinny, so if their fear is that they're afraid they're going to gain weight or that they're going to be unhealthy, again, first of all, you want to make sure there's not an eating disorder going on there, because if that's the case, then it's not OCD. But if it's around a fear of not being healthy, or then yes, actually getting them to eat different foods would be the ERP. In fact, I've had a couple clients that I've done that with, where we started off with chips, how hard would it be, how to rate how hard it would be to eat, so many chips a day. And then we moved into bits of chocolate and had her continually adding to that. So yes, you can go after anything. That's what I'm going to say. Once you know that fear, you can always find some type of way to go after it with ERP. I don't see any other questions. Oh, here we go. Another question. Can you delineate a bit the line between disordered eating and a food obsession? Okay, so with respect to disordered eating, we're going to want to know, so a lot of the questions you're going to want to look at are what's underlying the not wanting to eat junk food or whatever, or what is underlying them worrying about getting fat. And if all that's going on is that they're worried about being fat and they're restricting food because of it, then we're going to want to look a little deeper into what that fear is. And with respect to a food obsession, it's not generally about losing weight or being skinny. That would go more into potentially, again, a body dysmorphic disorder, where they're worrying about their body shape. It's less OCD. I do have clients who have OCD and have an eating disorder, or who eating is affected by it. And it was more around the idea that it was control. So they wanted to, that was their way of taking back control, was to eliminate or to certain foods. Others, it was around having to eat foods a certain way. So you want to kind of look at what's underlying it, and what, with respect to OCD, there's going to be a ritual. So I hope that answers the question. I'm not sure if it did. And I don't see any other questions.
We have about 1 minute left, Dr. Sapp. So if there are no more questions, perhaps I can wrap up. I don't know if anybody else has a last minute question there.
And did that answer your question? I'm hoping that answered your question. Okay.
Okay.
It seems a tricky place.
Tricky place.
It is, but basically, you can distinguish it. And again, it comes down to whether there's compulsions, and whether the compulsions are related to weight gain. Because if it's a fear of weight gain, we have to really make sure it's not just an eating disorder. But they can coexist.